All right, hello everyone. So, very happy New Year to all of you. I just hope, wish, and pray that this 2021 brings a lot of happiness and success for all of you and your families. So, I'm Dr. Tushar Mehta. I'm an orthopedic surgeon and a national level faculty of orthopedics for PG aspirants and the postgraduates. Today, this video is about a very important topic of upper limb osteology. We have heard about scapula, and I'm sure in your first year anatomy, when you were just freshers in your medical college, you read osteology, you read about scapula, and there was a small point which was written in the applied anatomy of scapula, which was called as Sprengel's deformity. I'm sure you have read this topic. It's a high elevated scapula that is called Sprengel's deformity. Today we will discuss this from a larger and a broader perspective. So let's begin. What is Sprengel's deformity? See, first of all, it's a congenital anomaly, not very commonly seen in clinical practice. It's a little rare one. Now, what it is all about, this is an interruption in the caudal migration of scapula. So ideally, at the time of birth and even before that, scapula is usually a high riding bone. So it should descend down. And when it does not descend down, if there is no normal caudal migration, if that is interrupted, then this is what we call as Sprengel's deformity. Now, what happens? I will discuss that in detail, but let me just tell you what happens broadly. So not only scapula is high riding, not only it is elevated, but there is a slight amount of medial rotation of the scapula as well. We will talk about all these things in detail. I'm sure with this image you can very well make out this high riding scapula here. So this is an interrupted caudal migration of scapula called as Sprengel's deformity. It is usually associated with certain clinical symptoms, one of which is a limited abduction beyond 90 degrees. So you can appreciate that this abduction beyond 90 degrees is a little difficult to achieve. Anyhow, we will go ahead with the topic, and I've always been very fond of talking slight about the history. So Eulenberg was the first person to describe, then Willett and Walsham described a couple of cases, but then finally, who is Sprengel? So it is Otto Gerhard Karl Sprengel. I mean, I don't want all of you to remember the names, but if you can remember it, that's good. So Otto Gerhard Karl Sprengel was the guy who described these cases, and therefore the word Sprengel's deformity came into existence. When we talk about the entire shoulder girdle, then this is the most common congenital anomaly. It is the most common congenital malformation. Age of presentation, I will not say that there is particular age of presentation, since most of the deformities are noticed at the time of birth. The child is born, and it is usually noticed by that time. Gender distribution, there is no literature to mention that who is more involved. So it is kind of an equal distribution, but yes, unilaterality is way more common as compared to bilaterality. I would say that bilaterality is very rare. It is almost 10%. Now, if it is unilateral, which is more common, then of course you should know that left-sided involvement is more seen. Left is more than right. That is what the literature says, the observation says, and the textbook says. You can see in this image, I have spoken about this as well, that bilaterality is very rare. That's hardly close to 10%. So unilateral is more common, and in that also left side is more common. So you can see a very rare bilateral anomaly here, and here you can see a unilateral anomaly, which is more common, which is more often seen. So now moving ahead, there is a small slide I put up here regarding the genetics part, although I mean it is hardly required for your clinical knowledge. The condition is sporadic, but yes, rarely autosomal dominant pattern of inheritance has been noted. Now let's come to the actual business. Let's come to the embryology, where the topic ideally should start. Now scapula is usually seen in front of the level of C4, C5, C6 at 5 weeks of gestation. Are you getting my point? So at 5 weeks of gestation, ideally scapula should lie at the level of, you can say, C4 to C6. आप ऐसे बोल सकते हो. Now, what happens is, it is what I'm talking about at the 5th week of gestation, or by the end of the 12th week, that is precisely, you can say, 3 months. So by 3 months of gestation, scapula should ideally come below T3. Are you getting my point? तो आप इसको ऐसे समझ लीजिए that 5th week and 12th week. So 5th week it is C4, C5, C6. 5th week it should be in front of C4, C5, C6. By 12th week it should come below, it should descend below T3. Now when this pattern is not followed, आप समझ रहे हैं मेरी बात को, when this pattern is not followed, that 5th week, 12th week, 5th week, C4 to C6, 12th week before T3, if this pattern is not followed, if this caudal migration is not followed, if that is interrupted, so you'll end up into a elevated scapula, hypoplastic scapula, medially rotated scapula, and Sprengel scapula or Sprengel's deformity. These landmarks are very important. The C5, मेरी बात समझ रहे हो बच्चे? The C5 landmark and T2 landmark is very important. I'll tell you in one of the slides ahead. So somewhere down the line we have understood the embryology. ठीक है? That 5th week, C4 to C6, 12th week, it should be below T3. This is the ideal descent pattern. If it is not followed, then you will end up into Sprengel's deformity. So the classical time of gestation in which majority of the Sprengels happen is 9th to 12th week. Are you able to understand my point? So 9th to 12th week is the classical point where this happens. Now many people they know, okay, there's an interruption in the the descent, the caudal migration of scapula, but it's not only to deal with scapula. It is not only to deal with bone. There are issues with the musculature also. There are issues with the cartilage also. There are issues with the adjacent joints also. Like there are certain muscles I would like to name here: trapezius, rhomboid, the levator scapulae. They may be absent, they may be hypoplastic. Serratus anterior, sometimes that becomes weak, leading to winging of scapula, leading to exaggerated deformity. Then there are certain other muscles. Pec major is there, sternocleidomastoid is there, latissimus dorsi is there. So they are also affected. So technically, I would say that almost all the muscles in and around that part can be affected. Okay. So it's not only a problem of scapula. It's a problem around in the musculature around scapula, and that is why when we'll come to the treatment part, the surgery part, of course we will not go into that depths of the surgical procedure because the clinical component is more important, the pathophysiology is more important, but still the majority of the surgeries will be dealing with the musculature around. What happens to scapula? First of all, the shape is distorted. Do not think that scapula will be just a high-rided bone without any change in the musculature. No, ऐसा नहीं होगा. Scapula will be high-rided, but apart from that, the shape will be dysplastic. I'll tell you how it will be dysplastic. First of all, it will be higher than the usual level. The second thing I want you to understand is that it will be smaller in the vertical plane and it will be larger horizontally. आप समझ रहे हैं? Scapula will be compressed vertically and it will be expanded horizontally. फैल जाती है थोड़ी सी, लंबाई कम हो जाएगी और चौड़ी ज़्यादा हो जाएगी. Now, I would like to say that it becomes more like a triangle, equilateral triangle, which normally it is not. Okay, so वो ऐसे होने की वजह से और ऐसे होने की वजह से, so it more or less looks like an equilateral triangle. So scapula is hypoplastic, it is expanded more horizontally than vertically. Then the second thing that I want you to understand that the medial rotation component, ये बहुत important है. The inferior angle of the scapula, it is rotated medially. So that is why when it is rotated medially, now just imagine there's a scapula. If it is rotated medially, then glenoid has to face inferiorly. Now I'm sure you guys are aware of a supraspinous part of scapula. I'm sure you are aware of it. Scapula mein there's a supraspinous part. So there's a spinous process. Na? So there's a supraspinous, infraspinous part, supraspinatus, infraspinatus, anatomy first year. So the supraspinous part, the convexity of the supraspinous part is increased. Now that leads to a problem that is something that has to articulate with the curvature of the clavicular shaft. So when convexity of the supraspinous part is increased, so the claviculo-scapular distance, or in other words the scapulo-clavicular distance, so that gets narrowed down. जिसकी वजह से there are chances of brachial plexus compression, and that is a very important reason why in certain surgeries of Sprengel's deformity we have to do morselization of the clavicle, because I'm telling you again, so there's a supraspinous part, normally it is convex, so the convexity is increased, so the distance between scapula and clavicle is decreased, because of which it leads to brachial plexus compression. So that is one pathophysiology. So bottom line remains the same, it is dysplastic. It is expanded more horizontally and decreased dimensions vertically. It is higher than the normal. The inferior angle is rotated medially so that the glenoid faces inferiorly, and then the convexity is increased, particularly of the supraspinous part of the scapula, leading to decreased scapulo-clavicular distance and brachial plexus compression. Now, there are certain associated anomalies. What are those associated anomalies? I'm sure you can see there are certain associated anomalies of spine. There are certain associated anomalies of ribs. Let's talk about ribs. Cervical rib. In majority of the cases of Sprengel deformity, you will see an associated cervical rib. You will see fused ribs. Now, as far as spine is concerned, in majority of the cases, you might observe spina bifida. But one hell of a deformity, we will talk about that also. Slight discussion will be there in one of the slides. Klippel-feil syndrome. Then hemivertebra can happen. Then scoliosis is one of the common associations. These are the associated issues, whether spine or ribs. Ribs, you will have a cervical rib or a fused rib. Spine, you can have a needle tube defect, you can have hemivertebra, you can have scoliosis, you can have klippel-feil anomaly. Now, there is one thing, I don't know whether in this image you can appreciate or not, but they have written here, they have labeled here omovertebral bone. ये बहुत important चीज है, इसका जिक्र होना चाहिए. It needs to be discussed. Omovertebral bone. Let's talk about omovertebral bone. By the way, these associations are shown in these two images also. Now, omovertebral bone has to be discussed. Approximately seen in 1/3 cases of Sprengel's deformity is an associated anomaly called as omovertebral bone. So, you understand my point? So, there are 10 cases of klippel-feil, 3 or 4 will have. There are 10 cases of Sprengel's deformity, 3 or 4 will have omovertebral bone. So, what is omovertebral bone? It is a rhomboid, sometimes trapezoid structure of a accessory cartilage or bone. But that's okay. The important part is that it starts from the supromedial border of the scapula. To make it simple, it starts from the superior border of scapula. I'll show you the images also. So it starts from superior border of the scapula and it goes towards the spinous process, the transverse process, or the lamini of C4 to C7. Maybe I think I should show you first. उससे आपको clarity आएगी. So this is what is your omovertebral bone. So it is a trapezoid or a rhomboid shaped accessory structure, might be cartilaginous or might be bony, usually bony, which extends from the supromedial, forget about it, it extends from the superior border of scapula and C4 to C7. ठीक है, the C4 to C7 के transverse process, spinous process or lamini, wherever it can go, it goes and gets attached over there. I hope that makes some sense to you. And do you see the omovertebral bone now? So this is a very, very important thing here. That is what is called as the omovertebral bone. Now this omovertebral bone is another important association of Sprengel deformity, and that is the reason why it does not allow the normal caudal migration of the scapula, identified usually on an X-ray of the cervical spine, usually not seen that great in AP, but better seen in a lateral or oblique X-ray. So omovertebral bone as such is a very important thing. It can be asked, in one of the Viva questions also. So you can very well say that it is one of the classical association of klippel-feil deformity and Sprengel's deformity, best seen on an X-ray of the cervical spine in lateral and oblique view. Accessory bone or cartilage, which is rhomboid or trapezoid shape, extending from the superior margin of the scapula and getting connected to the transverse process of, or the lamini or whatever the spinous process of C4 to C7. Now, I told you that I will be talking just a bit about klippel-feil deformity, because klippel-feil deformity is a classical association of Sprengel's deformity. What is klippel-feil? See, klippel-feil syndrome or klippel-feil deformity, better you call it syndrome, it is composed of a triad. It's very famous for its triad. The first part of the triad is a short webbed neck. You will have a child who will have a short webbed neck. Then there will be low posterior hairline. Now, if I had to look towards my left, I can look at like this. Towards my right, I can look at like this. This child can't. He has to rotate his entire body towards left and right. So, 3 components. Short webbed neck, low posterior hairline. And what is the third component? The third component is decreased mobility at neck. So, this is a classical triad. Now, what is klippel-feil? It's a congenital bony fusion of at least 2 or more cervical vertebrae. That is the basic definition. So there has to be a congenital bony fusion of two or more, at least two or more cervical vertebrae. They're supposed to be unite. There has to be a bony fusion. Now, it is a classical association of Sprengel deformity and vice versa. Now, in cervical spine, I'm sure you are aware that we have from C1 to C7, so which is the most common fused segment that you see, that is C6 to C7. C6 to C7 is the most common fused segment, that is in the lowermost part. So klippel-feil is a common association, and whenever you see a Sprengel deformity, you should exclude klippel-feil. Whenever you see klippel-feil, you will find a Sprengel associated to that. Now, how does this present clinically? See, there are two things that I want to talk about. One is cosmetic, one is functional. Why? I'll tell you the reason. You might have seen, maybe in your family, extended family, friends, neighborhood, कि कभी message आया, WhatsApp आया that a child is born like this and this is the shape of the back, or this is something in the back and family is finding something weird. Can you help? So you say, oh, this is Sprengel's deformity. The scapula is high writing. But then what are the issues? See, as far as, let's talk about the functional issues first. I think you remember in the first slide of the presentation, I told you that you can abduct till almost 90 to 100 or maybe 110 degree, but uske baad nahi ho payega. So there is a restricted movement at the shoulder, I agree. But beyond 90, 95, 100, 105 degrees. Ek baat. Dusri baat, the scapulothoracic movement, of course, that is restricted. Vertebral bone, distorted scapula, many reasons. Majority of the issues are cosmetic. So you have a high riding scapula. You have a scoliotic curve. Aega. Then you will have a torticollis also. You will have a condition that is called as caput obsteosum. So what is caput osteosum? Osteosum is an asymmetric development of the skull. So plagiocephaly bhi isko bolte hain. Then you will have a facial asymmetry also, because muscles of that side will be involved, whether it is sternocleidomastoid or trapezius or pec major or deltoid. So precisely a clinical feature. And then very important, clinical staging, Cavendish grading. This is an important thing which is usually asked in Viva exams, if at all you see a case of Sprengel's deformity. By the way, let me utilize this one moment to tell you that Sprengel deformity is not very common, but still it is a common short case. Normally, pediatric congenital anomalies, they don't give usually in PG exam, but if at all they give, then one common thing that they encounter is you can encounter as a student, as an exam going candidate, is Sprengel deformity, and Cavendish grading is something which will be asked. It's a clinical grading. It shows severity of Sprengel deformity. There are 4 grades, grade 1, 2, 3, 4. Simple, very mild, mild, moderate, severe. Very mild, mild, moderate, severe. First of all, very mild. Now, before I explain the grading, let me tell you, Cavendish grading is based upon 2 things. Number 1, what is the level of shoulders? आप समझना इस बात को. So there will be 2 things mainly. One is the level of shoulder. Second thing, whether the deformity is visible or not, with clothes on, off. ये बातें हैं इसमें. So I told you grade 1, 2, 3, 4, very mild, mild, moderate, severe. First of all, very mild. Now when we talk about the very mild staging, it is simple that shoulders are at level, and if the patient is dressed, hardly you can see anything. There's no deformity. So that is Cavendish grade 1, very mild, that level pe hai dono cheezein, you hardly see any deformity. Then you have level 2. When you have level 2, shoulders are against almost at level, which is category 2, grade 2, which is mild. Shoulders are again at level. But now, what? When the patient is dressed up, deformity is slightly visible, as in the form of a slight webbing of the neck. वैसे लगता है यहाँ पे थोड़ा सा, there's a slight web which is occurred. Then you come down to Cavendish category 3, which is moderate. In moderate, first of all, shoulders are not at level. One shoulder is slightly elevated. Deformity is visible with clothes, without clothes, whatever. Grade 4, boss, shoulder is highly elevated. And the most important part is that the superior angle of the scapula is almost touching the occiput. So there are 4 stages. Stage 1, you can understand it like this in Cavendish grading, clinical grading, very mild, mild, moderate, severe. Stage 1, stage 2, shoulders are at level. Stage 3, stage 4, they are not at level. Stage 3, it is elevated slightly. Stage 4, it is elevated to an extent that it is touching, scapula is touching the occiput. Stage 1, the person is dressed, you cannot see anything. Stage 1, with the person is dressed, the child is dressed, you can see slight webbing. Stage 3, stage 4 deformities, clear cut visible with the shirt on, off, whatever. So this is Cavendish grading. Clinical grading, when you see the patient, you talk about a diagnosis. Personally, I would say that it is a clinical diagnosis. Undoubtedly, there is no confusion. But then, of course, you get an X-ray done. I mean, I'm not saying that it is diagnosed only clinically, but yes, there's a high clinical index of suspicion, and then you get an X-ray done, X-ray of the cervical spine, and you get an X-ray of the chest also. You get an X-ray of the thoracic spine also, because you have to see the concomitant issues also. So you see a high riding scapula. But let me give you a little more about it. You see omovertebral bone, which we have already spoken about. I think you remember. Now, this is something which I want you to remember, that there are three things which we are going to understand. One is an elevated scapula. Second thing is the medial rotation of the inferior angle. And third is the OVB, the omovertebral bone. So, the elevated scapula, I'm repeating the points as I've said earlier, that scapula will not only be elevated, okay, it will be dysplastic. Not only be dysplastic, it will be expanded more horizontally rather than vertically, into an extent that it will resemble, just like an equilateral triangle. आपको याद होगा हमने बात की थी इस बारे में. Then rotation of the inferior angle. I hope you remember I told you that inferior angle will be migrated medially to an extent that glenoid starts facing inferiorly. हमने बात की थी. Omovertebral bone, we have discussed in length about omovertebral bone, a rhomboid trapezoid shaped structure, which is an accessory bone or cartilage connecting the superior angle of scapula to the spinous process laminae of C4 to C7, one of the classical associations. Clinically, we had a Cavendish grading. Radiologically, we have a Rigaults classification. Again, I discussed, see, this is what I want all of you to imbibe, that I have always focused upon this concept of connecting the dots. So that's why in anatomy I told you that there are two very important landmarks, if you remember, C5 and T2. मैंने बोला था आपको that at around 5 weeks of gestation it is in front of C4 to C6, that at 12 weeks of gestation it should be below T3. मैंने बोला था आपको. And these C5 and T2 are very important landmarks. Why? Because now you will come to know why they're important. So Cavendish grading was a clinical grading. Now we'll talk about Rigaults grading or Rigaults classification, which is a X-ray based classification. Very simple. There are two landmarks, C5 and T2. So according to Rigaults classification, Sprengel deformities are three types: type 1, type 2, type 3, right? My apologies. It will depend upon what? That what is the position of scapula, hai na? What is the position of scapula? So if your scapula, just listen to me, if your scapula is below T2, I will say it is just grade 1. If your scapula is lower than T2 and above T4, I'll say it is grade 1. But if your scapula is between C5 and T2, then I will say that it is grade 2. That's moderate kind of a thing. But if your supramendial angle of the scapula is extending above C5, I will say, boss, this is severe. मेरी बात समझ में आई कि नहीं? So if it is between T2 T4, I'll say okay, grade 1 mild. If it is between C5 T2, I'll say okay, it is moderate. If it is above C5, then I will say it is severe, it is serious, and one has to take care of it. So that is shown in the image. Also, we had already spoken about these two important anatomical landmarks. CT. I'll be very honest here that CT is mainly used for preoperative planning. The classical CT scan with NCCT with 3D reconstruction is basically used if you are performing a surgery, because you have to visualize the pathoanatomy, and I would say most importantly you have to visualize the omovertebral bar. I'm sure you can very well see this omovertebral bar here. अभी तो कोई confusion नहीं होना चाहिए आपको omovertebral bar में. So there is a classical omovertebral bar that you can see here, and the anterior convexity of the supraspinous process is increased, because of which the scapulo-clavicular distance is decreased, and we have already spoken about that. There are certain changes in the medial and lateral border. The concave thing becomes flat, the convex things becomes increased, and all these things can happen. Again, you can see an omovertebral bar. If you talk about Sprengel deformity, and if the examiner is not asking omovertebral bar, that means something is wrong. ये पक्का है या नहीं है? So if there's a short case of a Sprengel deformity, the first question is examiner will be like, okay, diagnosis, Sprengel deformity, leave it. What is omovertebral bar? So omovertebral bar is important. There are two differential diagnoses. One is the palsy, the long thoracic nerve. I hope you remember the LTN, the long thoracic nerve, or the nerve of Bell, or the nerve to serratus anterior, C5, C6, C7. I'm sure you guys know that, that is also one of the reasons for winging of scapula. When you press against a wall, the medial border of the scapula becomes prominent. So that is again one differential diagnosis. And the second differential diagnosis is spinal accessory palsy, the trapezius palsy. So that also leads to winging. So there are two types of winging. I'm sure you understand this. One is due to serratus palsy, another is due to trapezius palsy. So these are the two differential diagnoses. Now let's talk about prognosis. Before surgery, let's talk about prognosis. I will not say that it's more of a unfavorable prognosis, even despite the best of the surgeries. I'm not discouraging anyone for surgery, but whatever limited experience that I have had, and I've had the fortune of assisting, more than 6-7 cases, I have never seen a very drastic change in the cosmetic as well as the functional, capabilities of a patient. So what I would say that this mobility might increase. Maybe it can come down to this. Maybe it can come up to this. But still, some sort of asymmetry will be there. What are the factors to be assessed before performing surgery? The first thing and most important is the severity. That how severe is the problem? Cavendish is one guide to that. Rigault is one guide to that. So आप severity देखिए, दूसरा functional impairment देखिए. Because we are not treating the scapula, we are treating the person who has that high riding scapula. So one is the severity, maybe Cavendish or Rigaud. Second thing is the functional impairment, that whether he is able to follow his daily ordinary pursuits or not. कहीं ऐसा तो नहीं है कि the patient is still able to manage, at his normal, functional activities, but still we are enthusiastic to operate. ऐसा नहीं होना चाहिए. Third thing is age. We'll talk about that. Fourth is associated comorbid condition, associated congenital anomalies. 3 to 8 years is a golden period to operate. 3 to 8 years is a golden period to operate, I would say. Second thing is that the person should ask for it, the patient should ask for it, the family should ask for it, that nahi, he's not able to do this, which is a daily routine activity, then we might think of surgery. So these are two important points: 3 to 8 years, and significant deformity should be there, clinico cosmetically. Before 2 years, surgical intervention is not at all required, and if you perform surgery, after the window of 5 years, then I think you are going to get good results. We will talk about surgical treatments. I'll give you the names. I'll give you just a brief hint of the surgical procedures, because a couple of them have been asked. Like Woodward is something I remember that in one of the DNB theory exam, it was asked, I think, in 3 marks or something like that. So before we talk about that, these are certain important muscles. As we know that Sprengel deformity is not only a bony issue, but there are issues with the associated muscles in and around that part. So you should know their normal origin, insertion, nerve supply, and action. Again, you should know, osteology should be good. If you are, for an orthopedic surgeon, the basic thing is always anatomy. Nothing more than anatomy. Orthopedics, I always say, in my lectures, it is nothing but a glorified clinical anatomy where you get the license to, cut and heal. That's all. So anyhow, after this osteology component, after this basic anatomy component, the soft tissue muscle component, let's talk about surgical treatment. What a surgeon should plan: 3 things. If a surgeon starts thinking of surgery, the patient family says nahi kariye, because there is a lot of issues. Then you get an x-ray, you get a CT, you see all these things. Then a surgeon starts thinking of 3 things. First priority is always lowering down the scapula. The first priority is always, the caudal migration which has been interrupted. I have to make it possible. I have to bring the scapula down. For that, I might have to detach and reattach various insertions, various origins of the muscles in and around. वो तो करना ही पड़ेगा, है ना? If I have to bring the scapula down, certain muscles जिनके origin उखाड़ने पड़ेंगे, there are certain muscles जिनके insertion उखाड़ने पड़ेंगे, so I have to do that. First thing is that dealing with the muscles around the scapula to bring it, to lower it down. The second thing is definitely definitely the resection of the supromedial border and the omovertebral bar. वो करना पड़ेगा, because if you don't clip that supromedial border and omovertebral bar, then you are not going to achieve the free movement and the free abduction. I told you initially, if you remember, that in certain cases we need to perform the clavicular morselization also. So that is again an accessory step. Now, certain names: Potte's procedure, shock modified Potte's procedure. One of the questions which I have seen in one of the theory exams of DNB Orthopaedics: Woodward procedure, modified Woodward procedure, green scapuloplasty, modified green scapuloplasty, Mears procedure. Ideally, I would not ask you, I would not force you to remember the steps and go into the details, but you should know the bottom line. The bottom line will remain the same, that I have to detach and reattach the muscles around to bring the scapula down. I have to resect the omovertebral bar and the supromedial border. So exactly this is Potte's procedure. आप पढ़ सकते हो: detachment of the scapular, insertion of the rhomboides and trapezius, resection of the omovertebral bar, lowering the scapula and fixing the inferior angle to the rib at the level. So that is Potte's procedure. Then shock modified Potte's procedure. It said that not only you will do the subperiosteal dissection of the musculature, but they said no, we will add another osteotomy. So how shock modified? They added another supraspinous scapular area osteotomy and the base of acromion. So they said that no, not only you detach and reattach the muscles, apart from the subperiosteal dissection of the muscle, they said कि वो जो acromion का base and the supraspinous part of the scapula, we will do an osteotomy over there to bring the scapula down. So Potte's was basically a muscular thing. They added some osteotomy. Schrock added an osteotomy. You can remember it like this. Now, similarly, when we talk about green scapuloplasty, again the same. You have in pathoanatomy of this Sprengel deformity, you have the dysplastic, the prominent superior scapula border. So when you resect that, and you do the extraperiosteal division of the muscles to allow the scapula to come down, that is called green scapuloplasty. So this is again what is shown here. सब कुछ वही का वही दिखाया हुआ है. But again, you are not supposed to mug them up. Now again, the Potte's procedure was modified by Schrock. The green scapuloplasty was again modified. Now what they say is, that first of all, disinsertion of supraspinatus. Okay, fine. Then they say that you do a clavicular osteotomy. In green scapuloplasty, we were doing an osteotomy in the suprascapular border along with the acromial base. They say that no, you have to do a clavicular osteotomy, and then you have to do a limited release of the serratus anterior to allow the descent of the scapula. Now, why modified green scapuloplasty added one hell of a thing that is called as clavicular osteotomy? Because till modified green scapuloplasty, the thing which was seen was that even despite surgery or other, there was a significant postoperative complication of brachial plexus compression. Why? Because I hope you remember that there is too much of convexity of the supraspinous part of the scapula. Clavicular shaft is there, so the scapulo-clavicular distance was decreased. So even post-operatively, there was brachial plexus compression. So they said that by doing this clavicular osteotomy, the incidence of brachial plexus injury could be reduced. So this was a modified green scapuloplasty, where one thing which, so you're supposed to remember the catchwords. आप समझ रहे? So modified green scapuloplasty में the word clavicular resection, clavicular osteotomy is very important. Now Woodward procedure. Basically Woodward में था क्या, मैं आपको बताता हूँ. The only thing was they were wanting to put scapula into a pocket of trapezius. That's all what they wanted. So they said that the origin of trapezius, they wanted to shift to a more inferior position on the spinous process. That's the only thing that they wanted. They said कि ये trapezius है, ठीक है? It is it is dysplastic, it is hypoplastic, it is attached high up. They said उसको वहाँ से the origin of the trapezius should be detached from a spinous process and it should be shifted somewhere inferiorly. and then they wanted, place the scapula in the pocket of the trapezius. Now then, they went for a modified Woodward. In modified Woodward, again same thing was there, but there they wanted to correct the glenoid tilt also. I told you, glenoid started facing inferiorly. So they said, no, we will try to put some absorbable sutures so that the glenoid varus can be corrected and glenoid can face properly to the shoulder. So, you remember the keywords. मैं repeat कर देता हूँ, don't worry. I will remember the keywords. So in Potti's procedure, it is very simple. We are doing certain muscular things. We are attaching, detaching, reattaching, and putting scapula down. When you add osteotomy close to the supraspinous scapular area and the acromial base, we call it Schrock's modification of Potti. Green scapuloplasty, we do basically the same thing. The resection will be done and everything will be done. But in modified green scapuloplasty, we add clavicular resection or clavicular osteotomy to decrease the brachial plexus complication. Woodward, we are shifting the origin of trapezius down so that scapula can be kept in a pocket of trapezius. ऐसे समझ लो आप. Then modified Woodward में what we did an osteotomy so that glenoid varus can be corrected. आप ऐसे समझ लीजिए इसको. Are we able to understand this? So this is modified Woodward, basic thing that has been explained. And Woodward was something that I saw as one of the short notes, so you should be aware of it. So prone position, preparation of the part done till occiput, then a midline vertical incision, then detachment of the attachment of, you can see here is detachment of the attachment of trapezius and rhomboideus from the spinous process. So from the spinous process, you detach the attachment of rhomboideus and trapezius. Then सब में करना पड़ेगा. You have to release the omovertebral bar, you have to release the omovertebral band, then you have to excise the supromedial angle of the scapula. Why I'm giving you the steps of this particular thing is because of that DNB question that I saw. Then you relocate the scapula to a new position, you bring it slightly down, and then you suture the trapezius to the inferior spinous process. You are going to do that, and then you have to close in layers. So I hope modified Woodward makes some sense to you, so that when you solve that DNB question, you have a good amount of theory to write down. So prone posture, part preparation, midline vertical incision, detachment of rhomboideus and trapezius, then you have to clear the omovertebral band, you have to excise the supremedial angle of scapula, then you have to relocate the scapula, then you have to suture the trapezius to the inferior spinous process, and please close the wound in layers. Then there's a Mears procedure, which is reported in the last, in which 5 steps were given. First was, as usual and always with every procedure, that there should be a subperiosteal dissection of the scapular musculature, then extra periosteal excision of the omovertebral bone, then supraspinatus fossa osteotomy. Till now, the steps, you have heard them earlier, that you have to elevate the scapular musculature, you have to dissect or resect the omovertebral band, you have to do a supraspinatus fossa osteotomy, then you have to release the longet of triceps and a part of the teres minor, and then you have to resect the supralateral border of the scapula to gain main abduction. So these are the 5 important steps in Mears procedure. So same thing they have mentioned here. So these are the areas to be osteotomized. We have made a complete table here of all the surgeries, but still my request, whether you are a MS candidate or a DNB or a diploma orthopedics, that you should know, as far as all the surgical procedures are concerned, you should remember the names, whether it is Potti's or Schrock modified or green scapuloplasty or modified green scapuloplasty or Woodward or modified Woodward or Mears. But you should know the steps of modified Woodward procedure, and if at all you get a short note on Sprengel's deformity, you should mention modified Woodward in a bit detail. I think that will complete the topic. Now, post-operative complications, 3 complications. One is, which I have seen in one of the cases, is brachial plexus palsy. And as I said, that if you really wish to avoid, please go for clavicular morselization, because it is considered to be one of the most important steps now. Then winging of scapula. Sometimes we try to reattach serratus and we are not able to do that. So incomplete reattachment leads to winging and keloid formation. It's a normal complication that can happen with any surgery, so nothing unique in it. So these are the complications, and I think with this I come to the conclusion of the surgical treatment. Now, what happens post-surgery? Physiotherapy. Now, physiotherapy is very important here because you are playing with a lot of muscles. You are detaching some, reattaching some, you're shifting their origins, their insertions, you're making their pockets. Gradual mobilization, relaxed mobilization, passive mobilization, and yeah, you can use certain physiotherapy modalities. I'm not a very big fan of them. I would say that gradual, passive, relaxed mobilization is the key, and gradual abduction of the shoulder and elevation of the shoulder, one should work on it. And then posture correction is very important. So these are three, four things that we normally tell to the patients and their families at the time of discharge. So I think with this we come towards the end of this important clinical entity called as Sprengel's deformity or Sprengel's shoulder. I hope you have benefited from this. So thank you so much for this patient listening and watching. And now that we finished this video, I would like to inform one more thing here. So there's a portal called as Comprehensive Orthopedics, which is run on this website of mine, drtusharmehta.com. So now we are coming up in an app format as well. And since you know that I've been born and brought up in an institute called as Delhi Academy of Medical Sciences, DAMS. So now the e-medicos app of DAMS, which is one of the most highly anticipated apps in the PG preparation today. So we are starting a masterclass for PG residents in that eMedicos app also. So now you can watch all these important lectures and masterclass and videos on eMedicos also. So you can, whether you have an Android phone or a Google or a iPhone, you can go to the iTunes, you can go to the App Store basically, or the Play Store. So you can go there, you can download the app, and you can search for the masterclass orthopedics, and maybe you can subscribe there, and you can see all the videos of orthopedics for PGs there. So now you have options of two formats. So one is the website that has been highly appreciated, and we've got many subscribers in the last about 6 months. And now we're coming on an app format also, so that if you are having a phone in your pocket and you don't want to open a proper laptop, so you can watch it in the app format as well. Details are already there attached in this post related to this video. So if at all there is any other issue, you can reach out to me as on an email or message on Instagram or any of the social media handles that I have. They are usually by the name of Dr. Tushar Mehta. I'll be more than happy to help. So thank you so much. Have a great year ahead. Looking forward to see you again. God bless. Take care of your family and your loved ones. Bye bye.